Thank you, everybody, for joining the live session today into this report for the financial case for integrated mental health and supported housing pathways. I just introduced myself. I'm Chris Hampson, the Chief Executive, Look at Housing and Care. We're a specialist housing association that operates across London and the South East, and we work across mental health, learning disabilities, and homelessness, and children leaving care. We just wanted to really introduce today. Introduce this report, and we've got quite a great panel. I'll introduce in a minute. I'll just a couple of little bits first. Please do tweet about the event as we go using the hashtag. It's hashtag integrated MH for mental health, and ask any questions in the Q&A, and someone will be picking those up. We've got the report from Europe Economics. We're going to take that in a minute, and Deborah is going to take us through some slides. But before we do that, we wanted to start with a short film that I think captures the flavour of what integrated supported housing in the community for people with mental health needs actually looks like, and I think that sets the tone. So we just play the film now, and then I'll do some introductions.
We're supported housing, so we provide accommodation, but we also provide support within that. So that means that we're helping customers to develop independence.
I think it's a lot better going into a crisis house instead of a ward.
A lot of the time we see people come to us who haven't had support from mental health services, and they've kind of been living either on the streets or in B&Bs.
I was using substances, and that affected my mental health, and my mental health deteriorated, and I got diagnosed with paranoid schizophrenia.
I landed up at A&E and then Crisis House again. And Crisis House has been a haven.
Our flats are really spacious and nice. Like, I would love to have one of them. And so, you're going from being in a room to having a bedroom, a kitchen, a bathroom, a living room, and cooking for yourself all the time, and looking after your electricity bills and all that kind of stuff. And that's the kind of support that we're providing on a daily basis.
I felt like a king. I felt like I got a shower, I got my own room. What is this? What's going on here, And I felt very secure.
When I went to hospital, I didn't believe that I had a mental health illness, but now I can understand that I have a mental health illness. I need medication. I need a structure, routine.
I felt happy, and I felt really looked after. That's the word.
So many of our customers come to us from hospital, and they come to us primarily from a medium secure facility or a low secure step down that's associated with it. And I would say that most of our customers have been in hospital upwards of 10 years prior to coming to us.
It's kind of taking each day as it comes, what works best for each customer, because obviously everybody's different.
I play games with them, I play dominoes, cards, and it all depends. If they've got hospital appointments, I take them there, or if they can't get to the shops on their own, I'll go with them to the shops as well.
The staff went an extra mile for me. That's how I felt.
Proud of the service users more than anything. I'm proud that we help that person out.
It's so good to see how much they're improving, and like even just little things like, I don't know, Abby self-medicating now.
I can see the tangible effect that my work is having over a long period of time. Like, I can see people come to us from hospital, and then I can see them leaving our service, having gained the skills, having gained the confidence, having been able to manage their mental health, been able to reconnect with friends and family. It's something that I'll keep with me for the rest of my life.
Thank you for that. I think the film's great because I think it really captures the quality of life differences it makes to people. This report is actually about the financial benefits, but I think we must never forget the quality of life impact it has on people when they move into their own flat or home in the community. And that's such an important part of this. Okay, I've got a great panel. I just want to quickly introduce them before we see this, have a short number of slides. I'll introduce them. I'll start with Paul Bristow, MP. Paul's MP for Peterborough since the 2019 general election, and member of the Health and Social Care Committee since 2020. Since taking on his role, he has been campaigning in the House of Commons for social care workers, something that's very dear to our heart, to be valued in the same way as NHS doctors and nurses. We've also got Baroness Claire Tyler, Liberal Democrat Lord's spokesperson for mental health, and Claire became a Liberal Democrat peer in 2011. She is also chair of the Lord's Select Committee on Financial Exclusion and co-chair of the APPG on Wellbeing Economics and vice chair of the APPG on carers. And I've got Deborah Drury, who you'll hear from in a minute. She's the report author and managing consultant at Europe Economics. And Deborah is an economist and has worked for several healthcare professional regulators, as well as has a wealth of experience in economic impact assessments, advising private and public health clients across the healthcare sector. And we've got Paul Calaminus, interim chief executive, East London NHS Foundation Trust, and Paul's joined the trust in March 2017 as Chief Operating Officer. He's worked as a service director in South London and Maudsley NHS, otherwise known as SLAM, and then Chief Operating Officer at Camden and Islington NHS Foundation Trust. He graduated from Oxford University in 1995. So without further delay, I'm really going to hand over to what this is about to Deborah, from Europe Economics, and Deborah's going to run through just a few slides to get us going, and then I'm going to hand over to the panel. Deborah?
Great, thanks, Chris. Right, are my slides visible? Good. Thank you very much. I'm going to give you a very brief overview of our report. The full report, the executive summary, will be available afterwards for you to scrutinise. So Europe Economics, we were commissioned by Look Ahead to really investigate the cost savings and benefits that could be made with an integrated approach to mental health care. And for the purposes of our work, we've really focused on the definition of integrated care as combining the provision of clinical care, social care, and specifically housing and accommodation support. We saw in the video that that's really a key feature of the Look Ahead service provision. Our report begins with a broad review of the literature, looking at evidence for cost savings and improved outcomes from integrated mental health care across many countries. And then we hone in on 5 main service areas that Look Ahead provides. So these are the crisis and recovery houses, forensic step-down, rehabilitation services, and then other sort of in-community support services. We then look at cost savings. So we investigate the potential savings of Look Ahead services compared to in-hospital mental health care. We explore then the benefits to Look Ahead service users. And finally, we end with an illustrative exercise scaling up the potential costs, cost savings at the national level. So starting with the cost savings, we start with Look Ahead service users and compare the costs incurred by these services to what these users might have cost the NHS. And we really look at 2 kind of dimensions of cost savings. The first one being direct savings. So these are really direct cost differences between Look Ahead services and similar hospital-based care. So for example, the cost of a day at a Tower Hamlets crisis house compared to a day in an acute mental health ward. And these savings realised by Look Ahead could potentially be driven by a range of factors. So for example, perhaps a more tailored use of lower banded staff, perhaps lower overhead and estate costs, synergies and economies of scale. And an example here could be perhaps reducing duplicated time of clinical professionals if they're able to come into a tailored accommodation suite to treat patients at a time when they're likely to be most responsive to that treatment, to save sort of duplicated effort. That's one example of a potential cost saving from these synergies and the tailored accommodation. We then also looked at what we termed indirect savings, and these are really focused on freeing up hospital bed space. And these stem from the different outcomes that Look Ahead users experience to those in hospital wards. Again, some examples would be less time, and that's needed to be spent in a Look Ahead service compared to, say, a mental health hospital ward, lower readmission rates for Look Ahead service users compared to individuals who are in hospital wards. So all these contribute to indirect savings. Now, measuring the cost differences and savings between Look Ahead services and in-hospital care requires a selection of a range of sort of proxy cost and outcome data from the NHS. And we clearly had to make some assumptions about what types of hospital-based care these Look Ahead users may have used in the absence of the Look Ahead services, and therefore what savings could be attributed to Look Ahead. So we used a combination of Look Ahead data, so cost and outcomes data from Look Ahead. These included the costs of their tailored housing and accommodation. And then we used a range of sources from the NHS to proxy the in-hospital care prices. So for example, the price per day for an inpatient on an adult mental health ward, the average length of stay in an acute bed, the average readmission rate. And we compared these two sets of data to arrive at a cost saving per individual, which we then multiplied up by the number of Look Ahead service users in a year. And then our report, we also investigated the many benefits of Look Ahead's model of integrated care. And again, as we've seen in the video, these are multiple. So for example, accommodation that is safe, but also empowering, and that's tailored to the specific needs of the different service users. Clear improvements in mental health, specialist clinical support, and then also focusing on equipping service users with skills and for independent life in the community. It's perhaps worth noting that our report doesn't take a direct comparison of outcomes with hospital-based care. This would be, I suppose, a much more detailed and complex element of analysis. I think it's a valuable area of further research, but just to flag that is one thing that we have not looked at in this particular report. And so our findings really were that the potential cost savings and benefits from even just a subset of Look Ahead services really can be quite extensive. So this diagram is taken from our report. And it really just illustrates three key service areas. So the crisis and recovery houses, rehab services, forensic step down, our estimated cost savings by using a Look Ahead type service compared to an in-hospital service. And these are annual savings in total across all the service users that use Look Ahead. So we're looking at around about £5 million in a year just from these three services. And it's also worth saying that in addition to these three, there are many other services that Look Ahead provide, which we've touched on more qualitatively in our report. We've not quantified them due to things like data availability, but these will still offer valuable benefits, and they will also underpin cost savings, primarily through the prevention of further care. Then the final step in our report was really just to undertake an illustrative exercise to explore the potential savings that could be generated by scaling up the types of integrated care provided by Look Ahead more widely across the country. And to do this, we made an assumption that around about a third of current mental health patients who spend time in hospital could benefit from Look Ahead type services. And we estimated this, we multiplied this figure by our estimated cost savings across the Look Ahead service users. And this implies a saving of nearly £1 billion per year by using an integrated care model rather than in-hospital care pathways. Now, clearly this is an illustrative exercise, but nevertheless, I think it's very useful to demonstrate the potential size of cost savings. If anything, we've been conservative, particularly in terms of the numbers of mental health patients which could benefit. So by taking just a third of those currently spending time in hospital, that figure of the patients spending time in hospital is also fairly outdated, so it would be larger in today's data. And clearly there are many sort of clinical and policy and practical factors that need to be considered in any sort of scaling up. And I think that's really the purpose of this particular launch and the discussions currently underway, is how can we realistically extend integrated care so that similar cost savings and benefits can be realized. Good, and I think I'll hand back over to Chris.
Thank you, Deborah. That's a good trot through. It's interesting, isn't it? This report, unlike many other reports, is not about calling for new resources. Actually, it's about redirecting resources into the right area, and I think that's quite a big something we need to hold on to. And it's about freeing up resources so we put them in the right place, and that's crucial. Okay, and the other thing is this is about Look Ahead services, the report, but there are other providers like us who are doing the very similar things in London, in the Midlands, nationally. And they are dotted around the place. And I know that some of those people will be on the call and will be, jumping up and down saying, why can't we scale these up and have more of these services? And we're ready to go. So I just want to make those points. Okay, I want to go trot through, get some comments from the panel now, please. Paul, Bristow, if we start with your thoughts on the subject and the presentation, please, for a few minutes.
Well, thanks very much indeed, Chris. And you hit the nail on the head. Most lobbying efforts or reports or calls on government are usually always asking for more money to be spent, whereas the reforms you're putting forward today are very welcome because they save the country £1 billion, which is I'm sure the Chancellor would be very keen on at the moment. We are doing a very similar sort of inquiry at the moment on the Health and Social Care Select Committee, and some of the things that you've talked about today are incredibly valuable, because it's all about making sure that we integrate services, but at the same time, it's not just about money, it's about improving outcomes for service users at the same time. And it's clear from the earlier video we saw that this is what is the case. Now, social care, reform of social care can't be kicked down the road any further. It really, we really have to grasp the nettle and reform social care in quite the same way we perhaps we've got a 10-year plan for our NHS. We've got an NHS reform bill which has been proposed. What about social care? We need that long-term reform for social care, and it's going to be expensive because there's not enough money in social care at the moment. So if there's an opportunity to save money, then I think that can only be a positive. And I think it's only going to get worse, the issues surrounding mental health as we come out of this COVID crisis. It's clearly one of the things that we're all going to live with as a result of lockdown. It is the impact that it's had on people's mental health. And so some of the challenges that we're going to face are going to be more considerable, because we know that those with mental health challenges, need structure, need routine, need those things. And unfortunately, lockdown has deprived many of the people of that structure and of that routine. And integration is so important across the public sector because we can't have elements of the public sector just working in silos with one another. It really doesn't work, and it's bad for the system. It's bad for the service. It's bad for service users, and of course, it's bad for outcomes. And one of the things I think will come out of this COVID pandemic is the need to make our public sector more productive. Our NHS has done a fantastic job during this crisis. It's not been overwhelmed as many predicted. We didn't see people treated on the side of streets in places like, as we saw sadly in the continent and elsewhere. But one lesson for our National Health Service and our social care service is that it needs to become more productive. We've seen perhaps many years worth of productivity come from just a few months of lockdown. It was the spur really that forced the NHS and social care system to become more productive. And this is a solution, I think, that needs to be taken very seriously. Housing and mental health services are inextricably linked. And if we can get that reform right, and this is, I think we can deliver real savings to the taxpayer, but at the same time, real benefits to service users. And that's why I'm really excited about Look Ahead's report.
Good. Thank you, Paul. That's very helpful. I'll just quickly move on. Claire Tyler, please.
Yeah, thanks very much, Chris. I think it's a really excellent report. I think it makes very clear that the benefits of integrated and community-based mental health services, working with other aspects of healthcare, social care and housing support. And I must say, I was very taken by the film. I found that very compelling. I think it was the gentleman saying, "I've got a shower now," as if that was such an amazing thing. And that's really going to sort of stick with me. And I think, similarly to Paul, one of the things that this report brings home really strongly is that social care is not just about older people. Now, for very understandable reasons, they have been much of the focus since the start of the pandemic. But it's very clear from this report that other younger people and families, including people, those people with learning difficulties, mental health problems, and the homeless, have a great need of social care. And my view is that despite the very acute pressures on services due to the pandemic and other issues, including demographic factors, that actually now is a really propitious time to be launching this report. And I say that for three reasons, and Paul's already touched upon some of them. The first one is that the pandemic has cast a very, very harsh spotlight on the problems of our current social care system. Its sort of its shape, its structure, its funding. And I think we have got to the stage where it can no longer be ignored as it has been by successive governments, despite all the numerous reports and commissions on it. The second point is because I think the mental health has really become a big issue. Many people's particularly people with pre-existing mental health conditions, have deteriorated due to the pandemic. And other people have developed some mental health conditions and require so the demand for mental health services is really going up. And so it's going to be absolutely critical, I think, that we look at how mental health services can respond to this increased demand. And the third reason is because we do have, it only came out, I can't remember if it was last week or the week before, I think, this new white paper on the government's reforms for the NHS, and it's called Integration and Innovation. And actually, it is just so relevant to what we're talking about because, it's quite a long document. But in a nutshell, it's about really, frankly, moving away from the 2012 model, which was very much focused on competition, to a model which is much more about championing integrated care systems and collaboration. And it sort of seems to me that that's sort of, in a sense, those two things, collaboration and integrated care, is what this report is all about. And I mean, just one sentence I've just picked out from the white paper. It said, "The case couldn't be clearer for joining up and integrating care around people rather than around institutional silos. Care that focuses not just on treating particular conditions, but also on lifestyles, on healthy behaviour and on prevention." And I think that the one sort of reform which I'll pick out is that the NHS and local authorities will be given a duty of care to collaborate with each other. And that will be underpinned by local authorities being on the board of integrated care systems. So for me, and looking at the focus of today's report, the key question is, how do we actually get the housing sector and other third sector organisations and the voluntary sector also involved in these new health arrangements? Now, the white paper does make clear that we're still awaiting from government more detailed plans on social care, where they've committed, to come forward with plans this year, mental health, to reform the Mental Health Act, and public health. So actually, I think that's another reason why I think the timing of this report is timely, because frankly, there is a window in which to influence these further reforms which are coming coming down the path. Now, it's clear housing support is such an important part of this. I'm not pretending it's my area of expertise. It's not. I tend to focus more on, mental health and social care. But it does seem to me, and the film reinforced it, that housing support is very much the missing piece of the jigsaw if we are to see the sort of, the transformation of services that we're looking for. Now, how that's going to be achieved, I'm not 100% sure. I'm not sure yet. I think it's not clear from the white paper what the role of health and wellbeing boards might be. I mean, whether they're still going to be key parts of the infrastructure and the sort of the move for joining up, or whether I know the aspiration is that integrated care systems across the country will provide much more partnership between NHS trusts, local authorities, GPs, charities, and other providers at the sort of the place level. That idea of sort of, pooling together resources and having much more collaboration there. So, hopefully that will be part of that's going to help this agenda. But just before I finish, I would say that, a little bit of realism here. There's a long history in the NHS of reforms, of legislation, of policy papers and other sort of, transformation plans, talking all about integration, but frankly, not an awful lot changing as a result of that. And I think sometimes the problems behind too much use of hospitals and disjointed care is based in some of the workforce issues, staffing issues, some of the funding and the incentives, and it's not all around sort of structures. And certainly in Scotland and in Northern Ireland, where some of these reforms have been tried out, I know that various reviews of how effective integration has found that their impact can be limited because of the difficulties of, complex governance arrangements, difficulties of agreeing budgets, workforce planning, etc. And I think what comes out, and this is really my final point, is the key importance of good working relationships, some of the softer issues, the cultural issues, the leadership style, the sharing of skills and things like that. And I think that will be incredibly important moving ahead. So in conclusion, I think this report makes an excellent contribution in setting out the financial case. But we do need to make sure that the end result of all of this is actually improvements to the quality of life of individuals. That's what it's all about.
Thanks, Claire. That's really good. I think there have been a lot of people nodding there. I think bringing the human elements back into this is really, really important. And also, the third party here is housing, and we talk a lot about health and social care, but how can we bring housing in? Questions are coming through thick and fast already. Right, Paul Calaminus, Chief Executive of ALFT, you're in the thick of this. Can I hand over to you, please?
Yeah, absolutely. Thank you. So, I mean, first of all, it was really lovely to see examples from Tower Hamlets sort of worked on in this report, and a reflection of some of the relationships that are there in Tower Hamlets. And I really did just want to say a couple of things, because I think this report is a really good example, actually, of how thinking with service users about what they want and they need, shaping services around them across a whole range of agencies, having commissioners from a whole different number of sectors also put their population in the centre of their thinking and their planning, can end up with services where someone does indeed say on the video, I've got my own shower. But that didn't arrive by accident. And actually that came from putting people using the services right at the heart and saying, how do we do this as well as we can? And if we do it as well as we can trust that we will deliver value and we will deliver productivity. And actually there's a sort of false economy on not putting people at the heart and of not doing things at the best quality we can. And so I think, for me, the examples in this report are really good examples of how thinking about people, about their health, about their experiences, about indeed our staff experiences as well, because I was really struck in the video too, hearing, was it Nathan from Tabar Court talking about his perspective on seeing the benefit that the service can bring, how those things together can really generate value. And I think there is a sense of partnership in Tower Hamlets that's reflected in this report that is about how do we put our people, our service users in the centre of what we're trying to do, try and co-produce with them how services need to be. What is it in their lives that we can help and support with? And from there comes value, I think. And that's really what I wanted to say, because I think that's at the heart of what we're doing. And I also think that's actually at the heart of the financial benefits and case that this report very eloquently sets out. So thank you.
Thanks, Paul. Yes, and I think, just something particularly we've seen in East London work really well, and you hit the nail on the head here. It's about partnerships, because we're not going to look here to all other providers like us. Can't do this by ourselves. It's just not going to happen. And it's about partnerships and trust. When I say trust, I've worked at Lookhead for a long time. And, if you're working with the health sector and they want to put very complex people with forensic histories and complex needs and hand them over to you to work within the community, and so that you can run those services safely, it takes trust. And 10 years ago, I think they would have looked at a supported housing provider like Lookhead and go, actually, or others like us, no, we don't have that trust. But I think that's shifted, and that's been a big shift. And if we're going to get those partnerships working between housing providers, supported housing providers, social care and health, that trust in those partnerships is going to be crucial. Okay, we've got lots of questions rolling in. Just lots of questions actually. Just one quick one for each of you to think about. I'll put you on the spot here. What do you think would make what's the biggest barrier to scaling this up? It's all very well having good stuff in East London or South London or outside of London, but what's the barriers to making this, stopping this from happening more on a bigger scale? Because that's what we want here. If we achieve those savings, it has to happen on a bigger scale. I don't want to put any of you on the spot, but I might put someone on the spot and just quickly go around. Paul, Bristow? What do you think?
Yeah, I knew you'd choose me. Well, look, I mean, I think the biggest barrier is culture, actually. I think many of our health systems have an aversion to learning best practice. There's a not invented here syndrome sometimes within in our health systems, and that's not necessarily the fault of any individuals, but I just think sometimes we need to do more to overcome that culture. Perhaps putting a bit of innovation, into the culture, and dare I say risk. I think we need individuals within individual commissioners who are determined who are resolved to take a little bit of risk and try and do things differently. And when I say risk, I'm not talking about an uncalculated risk. I'm talking about on the basis of what's happened elsewhere. Learning best practice and demonstrating that things could be better. But I just think the NHS and commissioning sometimes within the social care sector is very risk averse and very loath at doing that. It's the not invented here syndrome. But I think with levers, with encouragement, with evidence, and a real determination to advance things at pace and scale, it can be done. I just hope that this reform and some of the things that Baroness Tyler was saying about integrated systems and the duties to collaborate with local authorities and some of those things will be that incentive to try and do things a little bit differently.
Yeah, thanks, Paul. I think you're right about risk. We have to take risks. It's measured risks and not being too risk averse. Baroness Tyler, what do you think might make the biggest difference?
Well, I think it's some of the things I started to sort of mention a bit earlier on is that people focus too much on the structural changes that are coming and don't realise, exactly as Paul has said, about the importance of the sort of, you know, the cultural issues, the sort of the local leadership styles, how inclusive they are, people being prepared to sort of share skills, share data, you know, just simple things like sort of sharing workforce planning and maybe workforce development and things like that. I think there probably will have to be some form of incentives injected, which actually encourages collaboration and integration, because I think, you know, those financial incentives can be really important. And then I think that there's a new set of relationships to build, and, you know, it's easier in some areas than others. I mean, frankly, let's be honest, in some areas it's been hard enough to get the join up between NHS trusts and local authorities, and there's a whole raft of reasons for that. And they're much better in some areas than in others. But, you know, we're no longer just talking about that. You know, that's important, but we're also talking about the linking with other sectors, particularly, you know, the housing sector, housing associations, charities and the voluntary sector. And that just requires a different sort of mindset. And I don't think it's the mindset that the NHS have always been best at. You know, there are some great examples that they're already, you know, there always are, but there are also examples of it being just far too much, you know, get your tanks off my lawn.
That's a very good point, Claire. And I think the issue of structure, if we all sit around waiting for structural changes before we do anything, we won't get anywhere. And it's about relationships, and we just simply can't do that. Yeah, good. Deborah, thoughts?
Yes, well, as an economist, one thing I would like to say is really just, I think evidence could be a very key input into all this. So we've shown a little bit of evidence about cost savings, but I think much more research and evidence of outcomes could really drive the political will to sort of push forward these integrated models. And whether you quantify this evidence or not, that the outcomes for service users must be measurable in all sorts of ways, and to have that real kind of evidence database behind decisions, I think can certainly drive the political will, and also drive good decision making about exactly where to focus. So perhaps there are a particular subset of services that look ahead and other providers offer that would be particularly valuable to focus on as a starting point. But I think it's difficult to make good decisions without the evidence on outcomes underpinning those.
Yeah, thank you. I agree. And Paul Calaminus?
Well, as you might expect from what I said before, I think my reflection would be that I've been in the NHS for 25 years now. I can say with some certainty that it's very, very possible to make structural changes, to create partnership forums, and do any number of other things which all aim at a goal, and to miss out your service users, and to miss out how you design with people what the service you're going to try and offer is, and why that would be, and indeed what outcomes you're trying to collect. And so for me, the single biggest question for any area, you know, any integrated care system, any trust, any provider is, can you describe how you are involving your service users in designing the outcomes, creating the service, delivering the service in many cases now, and thinking about what to do next, because that's got to be central, and it is very possible quite often that it isn't.
Yeah, thanks, Paul. And I think that's a real reminder. You know, when we started working in East London more with health a few years back, it was initially through a lot of the co-production work we were doing at a local level, and that certainly broke some of the barriers down. I think that's a reminder, an important reminder. And just on the structural changes, just an observation. I've seen this in some of the questions coming through. We've got the new integrated care systems, and we know, how is the voluntary and third sector going to lock into that? the third sector and the voluntary sector is a very disparate bunch of providers, from very small providers to large providers, all different shapes and forms, some housing associations, some not housing associations. How are they going to lock into that and feed into that process? And I think I just parked that up there, but I think that's going to be a real challenge. Okay, I've got a list of questions here, a difficult way to start for the panel. Question here for Paul Calaminus, actually. Someone has asked, have ELF seen benefits during the pandemic of having quite a integrated mental health pathway over the last year? I think that's quite an interesting question. Paul, any observations there?
Well, I mean, I think the straight answer is yes. I suppose, first of all, first and foremost, our service users have seen benefits. So people have continued to move through the different pathways. People have continued to use the crisis houses, you know, and so all that offer has continued. I mean, and I think too, people have continued to get that holistic support throughout the pandemic. We've been able to continue to offer that different range of options for people, which is really important. And you know, these offers didn't stop. They haven't stopped at any point through this whole period of pandemic. And I think that's definitely been a benefit when I look a bit more broadly, kind of across the public sector. And that's without really talking about the impact on individual people and the support they've received through the different schemes and the different interventions. Yeah. You know, one that Deborah didn't talk about so much, but was on one of the slides, was the community support for rehab, which has been tremendously important to a good I think it's nearly 200 people, isn't it, on the caseload of that team? But you know, a significant number of people in the borough through a period of real uncertainty and real potential distress, and keeping focused on their outcomes. So in a nutshell, yes, we have seen benefits.
Yeah. Good, thanks. It's very interesting. What if you have those relationships as a provider with health and social care, it opens up other doors for partnership working. We know that during the pandemic, we've worked with two other trusts, one in North London, both in North London actually, one in North East London, one in North London, to access winter care funding to set up floating support and outreach services to help them with their hospital discharge. And that would never have happened if we weren't running other services there. People knew who to pick the phone up to on our side, on their side. Look, can you set this up? And I know I've spoken to other providers who are doing it. So once you have those established partnerships, you can do other more innovative things as well. Another question here, which I think is pretty good because it raises the issue of buildings, capital and housing. It says, does your analysis include capital cost to build the facilities, or is housing already available? And that's an interesting question, I think, to think about, because I can certainly say some of the examples we have used, housing doesn't appear overnight. It's got to be, you know, sometimes I think it's historical accidents, or whatever, that some boroughs or geographies already have supported housing there, and it's been able to be repurposed for these purposes over many years. But if you don't have that housing in your geographical area, you have to start from scratch. So it's kind of raises the housing question. How can we bring housing more into the domain? And if we are going to achieve these savings, we're going to have more supported housing, and that's funded through a whole different stream. It's funded through Homes for England. It's regulated by the Regulator of Social Housing. It's under a different, but I think it's something Claire Tyler said before. There's quite a concentration in terms of capital funding for housing, for supported housing around older people, which is good, but it often misses out mental health and to a lesser degree learning disabilities as well. So I think it's a general question, you know, if you haven't got supported housing, what do we do? How can we bring housing more to the table here? Observations? Who wants to? Anyone want to have a go at this? Claire, Tyler, Baroness, you want to have thoughts on this?
Well, I did say earlier on that I'm not really an expert on housing at all, but I mean, just a couple of rather general and basic points. Well, two things really. I think as well as the sort of the clear emphasis we're seeing in the white paper on partnership working at local level or sub-regional level through the integrated care systems, we also need to see more joined up sort of thinking and planning at national level through the different bits of central government who are responsible for the various funding streams that you're referring to, Chris. And I've recently become a member of the Lords. The Lords has got a new select committee on public services, and one of the things we're looking at actually is join up both at national government level as well as at sort of at local level. So I think that the sort of the way that government operates here can't be sort of left to one side. My second point is obviously, you know, there's a lot of good aspiration in the white paper, but there's a lot more detail to be hammered out. And you know, when the legislation is, I mean, I think the plan is just to introduce it quite quickly in Parliament. You know, I think it might reach the Commons. I don't know, even before the end of summer break or, you know, early afterwards. I'm not quite sure. When we see things like, you know, we've got this duty to collaborate, it will be really interesting who's included in that. You know, we'll sort of social housing sector in some way, and then it's difficult because it's a big and sort of complicated sector. It's quite difficult to sort of define. But I think, you know, just things like the list of people who are included in that duty to collaborate will be important.
Yeah, I think that's a really big point, Susan. I know you're not a specialist in housing, Claire, but yeah, that's right. We got to bring that together. Paul Bristow, any observations about that?
Well, just on that about the duty to collaborate, I mean, I think the intention behind the duty is to try and, as we've discussed, to get people talking about how services can be provided through relationship and collaboration and integration. I think that is the whole point about it. Unfortunately, when you put these duties in place within legislation, they don't always doesn't always materialize in the way that it was intended. I remember the last reform, there was a duty to innovate and a duty for research, and you know, it very much becomes a tick box exercise rather than something which is much more useful. We have found wherever public services operate in a multidisciplinary or integrated way, then outcomes are better for patients. That, I think, is the intention behind it, and we've just got to hope that it happens, because it does happen in certain places. There's, I think, was it either Paul or yourself, Chris, was talking about, you know, where you were contacted. I think it was you, Chris. You were contacted at short notice and were able to support a local authority very quickly. I just think that's the intention behind the reform, and hopefully it can materialise in a way which is satisfactory. I think it all comes down to that best practice again. If we can show where collaboration has worked and delivered outcomes in the way that we wanted, including those with housing, then hopefully with this duty in place, there will be some sort of lever or mechanism within the system to pump that out again at pace and scale, because that's always the challenge. It's rolling things out at pace and scale.
You touched on something, Paul, about outcomes there, which I think is very important. I don't think the housing world is always very good. The supported housing world is capturing the outcomes from the work we do to give the evidence base to those who need to fund these services. And, you know, this is what obviously we've tried to do a bit with this report, but we need to get better at capturing that data and looking at those long-term outcomes to provide the evidence to government and to the NHS, etc. Deborah, any thoughts on this, bringing housing in from you?
Yes, I suppose, I mean, perhaps this is a naive thought on my part, but one of the things we focused on in terms of the indirect cost savings is this concept of freeing up resources from hospital-based care. So there may be some scope in terms of how funding networks work to transfer some of the resources that are freed up by users, patients who no longer have to stay in a hospital ward for X number of days. They can be using these supported services, and a transfer of that funding could help with building necessary accommodation, so that you're not just focusing on hospital and housing support as two separate streams, but that you're almost looking at the funding in total and thinking, where is that money best spent?
Yes. No, I agree. Thank you. Paul, anything on this? I mean, you have got supported housing in your area, but it's still work. You can still have that, and it doesn't work very well. It might not, the systems may not work as well as they have.
I think it's one of the challenges I think going forwards actually is about how you create a funding and funding and commissioning system that really enables you to think about pooled budgets. So you can get so far thinking about health and social care being integrated and budgets being pooled. I do think it's a real challenge, and it's one that does need to be cracked eventually, about how you can think about funding to support people rather than episodes or individual days in hospital, because of course we are talking about a number of areas of service here where you've got some really fixed kind of costs, whereas actually a lot of what's in the report are really such important examples of if you work well with your service users and together, you can really stop readmissions to hospital, you can stop adverse outcomes and so on. But there's a lot of work to do, I think, on a commissioning framework that really supports that.
Yes, that's very interesting. The commissioning framework, I think it sort of leads into the next question. Someone has asked, how have been able to establish these models of service delivery in terms of finance and commissioning? But that comes back to everything we've been talking about. I think it's we can't just set up these services by ourselves. We need funding for them, and you need a commissioning framework that's going to work for that. And this has also led on to a question around how do we get a forensics? How do you get a forensic and crisis service that's mentioned in the report up and running? I don't know who's best to talk about that. But I know that to get forensic services, there've been quite a few questions on this. How do you get those established in the community, and with the fear of a lot of the risks and fear that go round with that from all sides? And Paul, I don't know, Paul Calaminus, if you want to comment on that, because I know when we set up a scheme, and there are other schemes, but with you, it took 2 or 3 years to get that off the ground. And I dare say if we wanted to set another one up, we wouldn't want it to take as long, but it didn't just involve Lookhead and the trust and the CCG, but I think it involved a lot of work from the local authority as well, and the support from the local authority to get that off the ground. Is there any way, people listening to this and wanting to get these sort of schemes off the ground, is there any way we can accelerate or speed this up? Any words of advice here? Because there's quite a few questions around this.
I mean, it's quite a question. I mean, I think the sort of starting point has got to be about. I don't want to repeat what we've already said, but the starting point has got to be about partnership, and it's got to be about partnership with your local authority and local politicians and local community leaders and all the people who are going to be affected. Because I've never, in all the places I've worked, actually not had quite a degree of conversation, if I can put it like that, with local communities and local people when schemes like this are being established. I think done well though, those conversations, again, those interactions can lead to real community support. So that's the other thing to say, is that actually with that engagement, with that work, with a real understanding within local authorities in particular of and health more widely about the reasons behind changes that are coming, the benefits to local people. It is certainly possible to set up schemes that are well integrated into the community, but I don't know. I haven't got I've yet to find the kind of magic, the answer to how you do that quickly, because I've not experienced that ever being a quick process, if I'm honest.
I think there'd be a danger in doing it too quickly, Paul, as well. I think you have to go quickly and very cautiously. Baroness Clayton, have you any observations on this and your experience of mental health? And this is, the forensic mental health services are very important, and it's important to have community-based services as well. Any observations?
I'm not sure I've got much to add to what Paul has said. I mean, I think it is a good aspiration to have more a wider range of mental health services in the community. But it's certainly not the sort of thing that's going to happen overnight. You could imagine there would be some concerns by some people about how it would all operate. It would require, I think, some real building up of relationships and sort of, good trust and all of that to get it operating properly. So I think, as I say, I don't think I can add very much to what Paul said.
Yeah, that's fine. Yeah, I know many years ago we did one. This is further out East London, and it was all set up. And at the time, there was so much. People were so risk averse that it was all set up with the teams, and we worked in partnership, and it sat there virtually empty for a year. Every time you got a referral, the referral broke down. So I think you have to have those partnerships. It's great to have the ideas, but you have to unblock all the potential blockages there. Listen, we're coming to the end of the session. I'm going to wind it up. Does anyone else from the panel want anything else to say finally before I wrap things up? Paul?
I mean, perhaps it's been said before, but I think it's just worth just ending on this note. Look, the time for this innovative way of thinking and this integrated way of thinking is now. There are so many opportunities that have presented themselves from the white paper and the reform that's coming up, and that kind of push to integrated care systems, and from COVID-19. And I'm loath to use the phrase that an opportunity has been presented by COVID-19, because it's obviously a very difficult and distressing time for everyone. Many have lost their lives before their time, and the mental health challenges that people are suffering are acute. But what the NHS and our social care system have done as a result of COVID-19 is really kind of stepped up and understood that they need to become more productive. And so there is an opportunity here to be grasped, because reform is necessary. It can't be stalled any longer. And I just hope that the decision makers take a long, hard look at your report and its recommendations.
Yeah, I think that's a good way to end it. I think COVID has shone a spotlight on the need for us to work together in partnerships. And I know where we had those relationships in the early stages last March and April and May, where we needed to get PPE equipment quickly to all those frontline services. It's where we had those established relationships. We had commissioning teams and trusts running around to our schemes, putting them in, because they had those partnerships and relationships. And we automatically saw some really flourishing relationships, if you like. So let's build on that, and let's grab the opportunity now. And I think it's a good time to do this. Good. I'm going to wrap up there. Just to remind the audience that the report will be all sent to them. It's available on our website. And we've had quite a lot of people dropping in on this. And I think what's really interesting about this event is it's an event where we've got equal numbers of people from health, social care and housing dropping in, that it's caught their attention. Quite often we do things in our bubbles, don't we? But this has been truly, about 160 people coming in. It's right across the sector. Can I remind people to also tweet and to use hashtag as well to keep this moving. But I want to thank all our panelists in particular for taking the time to drop in, and it's been a very, very valuable discussion. And let's keep things going, because I think if we can break down some of these barriers, it's great. So on that note, I think I'm going to end the event, but thank you very, very much.
Thank you, Chris.